We are delighted to announce our 20th anniversary in BHRT, and we are very excited to invite you all to San Francisco on March 3rd through the 6th. Dr. Pamela Smith will be sharing the stage with Dr. Terry Hertog, Dr. Ron Rosenberg, Dr. Jonathan Wright, and Dr. Jennifer Landa for 4 days of learning the latest in BHRT. Thank you everyone for joining Dr. Smith tonight as she shares her expertise in bioidentical hormone replacement therapy. Dr. Pamela Smith is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. She also holds a master's in public health degree along with a master's degree in metabolic and nutritional medicine. Dr. Smith is currently the director of the Center for Healthy Living and Longevity and the founder and chair of the Fellowship in Metabolic and Nutritional Medicine. Dr. Smith is also the co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine at the University of South Florida. Due to the very high attendance this evening, please submit your questions by using the chat option, and we will address questions at the end of the webinar. Dr. Smith, thank you so much for joining us. I will turn the webinar over to you.
Good evening, everybody. Glad to have you attending. We hope you do join us for the BHRT Symposium, March 3 through 6 in San Francisco. Tonight you're going to get a little flavor of some of the things that we're going to look at. And one of my favorite subjects is always to look at case histories. So we're going to look at a few case histories in bioidentical hormone replacement. These are going to be in men and women. For men, a little bit easier. They make 4 to 8 milligrams of testosterone in a day. Women a little bit different because, as you know, they have 28-day cycles. So on this slide is the 24-hour production rates of sex steroids in women at different stages of the menstrual cycle. So as you can see, for example, a woman at the peak, which is pre-ovulatory for testosterone, she only makes 171 micrograms in a day. When we look at estradiol, she makes the most pre-ovulatory, and again, that's 380 micrograms. When it comes to progesterone, she makes more mid-luteal, which is 25 milligrams. And when we look at DHEA, it's pretty consistent at 7 milligrams throughout the month. And so keep these things in mind because when we look at hormone replacement, we want to be physiological. It's also very important to start low and go slow. We're much more successful with hormone replacement if initially we start low, and if we need to add more, we can. If we start too high and we have to back down, then it's much harder on us and our patients. So let's look at a few case histories, keeping in mind that men make 4 to 8 milligrams of testosterone a day, and women have the cyclic variation that they go through, and we always want to be physiological when we replace hormones. A lot of people will ask, do all women need hormone replacement? Actually, they do not. If people are not stressed, then commonly after menopause, they will make the amount of hormones that they need. In the BHRT Symposium, we will be looking at men and women of all different ages, and we'll be looking at different modalities of testing. So tonight in these case histories, we're going to look at salivary testing, which is one of the ways of measuring hormones. So let's look at case 1. This is a 52-year-old female, the chief complaint of fatigue and insomnia. Past history is significant for surgery to the right foot. Family history, the mother has Graves' disease, father's healthy. Social history, this patient works as a school teacher and has a lot of stress on her job. When she came to me, because these are actually all my cases in my practice, she was already on progesterone 300 milligrams, sustained release in the evening. In the United States, the nomenclature, and in Canada, Australia, and many other countries, the nomenclature for sustained release has now been changed to E4M. That's E4M. So you'll now see many prescriptions written with that nomenclature, which is really extended release. Physical examination within normal limits, except for the patient just appears very tired. Now remember, her chief complaints are fatigue and insomnia. So of course there's many things we would want to consider here when we look at fatigue. We want to make sure the patient's not anemic. We want to make sure they're not hypothyroid or hyperthyroid for that matter. We want to make sure they don't have an infection like Epstein-Barr, cytomegalovirus. Perhaps they have a mitochondrial dysfunction. But since we're talking about hormones tonight, let's keep our focus here on hormonal function. But of course, we want to make sure the patient doesn't have any other issues. And the same thing occurs with insomnia. Very important that the patient sleeps well, because if they don't, they have insomnia consistently, it drives up insulin. It drives up cortisol. It really is a hormonal symphony, and so all these hormones have to play in too. This is a salivary test for this patient, and in this particular company, and there are many companies that do a great job, this is just one of them, green is the average person in North America, and red is one standard deviation above or below. The first thing you can see on the left-hand side is testosterone right here. Testosterone says less than 30, so the patient really doesn't have any testosterone. There's estrone, E1, which is normal. Estriol's at the bottom, it says NR, which means the patient doesn't have any estriol. Estradiol is on the right-hand side here at the top. Estradiol in this particular saliva testing company needs to be 6 to maintain function. She's at 5.1. So this is a menopausal woman, and so she would benefit from a small amount of estrogen. I'm going to come back to that statement. Here, the progesterone is actually above normal, so therefore the last one is the progesterone to E2 ratio is high because she's on too much progesterone. Progesterone is very interesting. Too much or too little can cause the exact same symptoms. So anxiety, irritability, insomnia, mood swings, depression, fatigue. So really, her other studies were normal. This person is out of balance in hormones. If she doesn't have testosterone, she'll have fatigue. Too much progesterone, fatigue. Not enough estradiol, she'll have fatigue, and commonly insomnia. Too much progesterone, insomnia, and fatigue. So really, this is a patient out of balance. So what do we want to do? We want to start her on testosterone, which is always given transdermally. And so again, start low, go slow. She's probably going to need somewhere between 1 and 2 milligrams of testosterone transdermally because she doesn't have any testosterone. But again, start low. Perhaps testosterone 0.75 milligram cream to 1 milligram. Too much testosterone, she can get acne or facial hair, so you'll not be very popular to this patient if you give her too much. So I actually started her on testosterone 0.75 milligrams. We usually don't go above 4 milligrams of testosterone transdermally in women. So that's kind of the upper limit of normal you would want to prescribe. Here again, she has no estriol and almost enough estradiol. So I gave her a small amount. I gave her biased cream, biased meaning E2 and E3. We don't want to give triest. We don't replace E1. So we just replace E2 and E3. So I gave her a small amount. Biased cream, 0.25 milligrams. But remember, you can make it any ratio you want because it's going to be compounded. And so I ended up giving her 90% E3 and 10% E2, since she had almost enough E2 but no E3. And then I decreased her dose of progesterone down significantly. As you can see here, she's on progesterone 300. She's way, way too high. So I took her down to 175 milligrams. And then that one's PO. The estrogen and testosterone, again, are transdermal creams. This is melatonin. Melatonin can be measured, and we do suggest you measure melatonin because if you give too much melatonin, then serotonin can go down. And melatonin is a saliva test. It's measured in the morning, in the afternoon, and 3 a.m. with the lights off. And this person had a very normal specimen in the morning and at 5 p.m., but it was low at 3 a.m. So I asked her, did you turn the lights off or the lights off continuously when you did this test? And she forgot and turned on the lights, so the test was not accurate. The next on this same saliva test is cortisol in this big box. Green is the average person, yellow 1 standard deviation above and below, red 2 standard deviations. And I'd like to get what we call a 4-point cortisol, where we actually measure cortisol 4 times during the day, an hour after the patient gets up, around 12 noon, around 4 to 5 p.m., and around 10 to 11 p.m. at night. And again, you want a dead center of green. And this patient was high in the morning. She was normal by noontime, but she was high at 4 p.m. and 11 p.m. And so what do we want to do? Stress reduction techniques are always very important. Prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, all of these very important. If cortisol is too high or too low, then you can give adaptogenic herbs like ashwagandha, ginseng, rhodiola, things of this nature. Very, very important because cortisol here, 3 out of 4 specimens, too high. So I gave her some adaptogenic herbs. She was a little stressed and wired, so I also gave her some calming herbs like lemon balm and chamomile. She was not on a multivitamin, so I started her on one because the adrenal glands really need a multivitamin. The DHEA is low. It really belongs dead center of green. It commonly is low in her age group. It can also go low due to stress. So again, start low, go slow. You can give DHEA as a pill or as a cream, and I opted to give her a small amount. She got 3.5 milligrams sustained release. And I usually give it in the morning because DHEA can invigorate people. So since she already has insomnia, giving it in the morning is a good idea. The same thing holds true of the adaptogenic herb ginseng. It can be very invigorating, so it's usually given twice a day. I have people take it in the morning and around 5 p.m., but not later at night because, again, they can become an insomniac. The last one on the bottom is the DHEA to cortisol ratio, and the DHEA is low because DHEA here is low and cortisol is high. So we've discovered the cause of this person's problems. Hormones were not balanced, caused the fatigue and the insomnia. It will take about 30 days for the patient to go back and rewrite the progesterone. It will take up to 90 days for the estrogen to take total effect and up to 60 days for the DHEA and testosterone. So I usually let the patient know it's going to be about 90 days before the female hormones and DHEA are balanced, but it can take up to 1 year for cortisol to normalize. Remember, she has a stressful job. So you want to make sure the person has the right expectations. So again, we're going to be looking at cases like this. So that's what we did with this patient. Case number 2 is a 64-year-old male, the chief complaint that he falls asleep after dinner. Past history unremarkable, he's an auto worker. He's already on testosterone, DHEA, and pregnenolone. Some of the cases we're going to be discussing at the BHRT Symposium in San Francisco are patients already on hormones. Some of them are people not on hormones yet. And this way you'll know how to treat either kind of patient. Patients on testosterone, 17 milligram cream, DHEA and pregnenolone combined together, and you see the dosages there as a sustained release capsule. Review of systems, the patient had no other complaints. Physical examination was non-contributory. And this is a saliva test, different company. Again, there's a lot of great companies that make saliva tests. And as you can see, this patient, we want to measure in males estrogen. It's very important that males have estrogen for memory and bone structure. Too much estrogen can make them effeminate. It can increase their risk of heart disease and increase their risk of prostate cancer. So we want their estrogen levels to be perfect, and in men we measure E1 and E2. So both of his were in range. We now more and more are measuring progesterone in males. His was normal, but you can see his testosterone's low. He was on 17 milligrams of testosterone, so one of two things is going on. Either number one, he wasn't rubbing in the cream well, or he wasn't putting it in a place it could get absorbed because he was using it transdermally, or he was not on enough. Usually for males, we suggest with transdermally applied cream that they put it either on the inner thigh where there's less hair or on the top of the foot. Those are two great locations. And really we want to turn back the clock so that his testosterone level is more like what he was when he was 35 to 40 and not 64. So when I talked to him, it did sound like he was rubbing in the testosterone. He was putting it on the top of his foot. So I did increase his dose to 25 milligram cream. DHEA, we would like to see dead center of normal. He was on 20 milligrams of DHEA already, so we did increase the dose. Men tolerate a much higher dose of DHEA than women, and so we moved him from 20 to 30 milligrams orally. His cortisol level was high, as you can see in the evening on the graph below, and on the top graph as well. So again, the same things. Stress reduction techniques, multivitamin, adaptogenic herbs, calming herbs if needed. So remember, his chief complaint was he was falling asleep after dinner. Giving him more testosterone and DHEA can help those symptoms along with normalizing cortisol. And so again, male patients tend to be a little bit easier than females. And on this particular saliva testing company, they do ask for symptoms, and these were the symptoms that he complained of. In case number 3, this is a 20-year-old patient with the chief complaint that she does not cycle on a regular basis. Past history, family history are remarkable. She's in college. She's not on any medicines or any nutrients. Review of systems was negative, and physical examination was unremarkable. And we would expect by the age of 18 that she would be cycling on a regular basis. So in these kind of patients, particularly in women under the age of 42, whether we're looking at PMS, PCOS, whether we're looking at infertility, postpartum depression, early perimenopause, I do like to do a 28-day test. That's a 28-day saliva test where we measure 11 days out of the 28, because this usually gives us a really good idea of where we stand. This is her melatonin, very normal looking. The top graph here in the green is estradiol. You can see the little black squares are her 11 specimens, and a couple of days she's too low, a couple of days she's too high, but on average she's pretty normal looking. The blue graph is progesterone. Again, you can see the 11 black squares connected together with a line. It's supposed to go up at mid-luteal and come back down as she ovulates, and she did not. So this patient did not ovulate, so hence, not surprising that she didn't have regular cycles. And then on the bottom you see testosterone. And she's way high, so your diagnosis is here when you do a 28-day test. It's polycystic ovarian syndrome. So not ovulating, not enough progesterone, testosterone too high. So what are we going to do for this patient? One of my favorite ways to lower testosterone, and you're going to learn several ways at the BHRT Symposium, but my personal favorite is to give saw palmetto, that's an herb, 240 to 260 milligrams BID. This can be very effective to lower testosterone without side effects. In order to regulate her cycle, she will need some progesterone. Commonly in this age group, we give progesterone transdermally. The average dose of progesterone given transdermally in industrialized countries is 20 milligram cream. That is what I gave her, and you use it days 14 through 25. And it usually takes 1 to 3 months before the cycle regulates itself out. If you don't know when to start, you can actually kind of see here what day of the cycle she's on, because you have 28 days worth of material to look at. Her cortisol was normal in the morning, a little high in the afternoon, evening, and normalized by 11 p.m. Multivitamin, stress reduction techniques, and adaptogenic herbs. And her DHEA was very normal. So really, PCOS. So again, we gave her progesterone. When you do that, do let her know that this increases her risk of getting pregnant. And so she needs to use another form of birth control. And then we gave her saw palmetto to lower the testosterone. We do want to get an ultrasound of the pelvis to see what is going on there as well. At this 36-year-old patient, chief complaint, she's been trying to get pregnant for 5 years with no luck. Past history unremarkable, patient's not on any medicines. This person is a physician. Again, these are my actual patients. Family history, father has hypertension. This doctor works 100 hours a week and she has a lot of stress. Physical examination's unremarkable. So obviously we're looking at hormones here because we're looking at infertility. So we did do a 28-day saliva test. Here melatonin is a little high in the morning, normal the rest of the time. The top graph again is estrogen. She actually has too much estrogen. Her progesterone, she does ovulate around day 11 or 12, and perhaps she ovulated again on day 28. But she is ovulating, and if at the bottom you can see her testosterone is normal. So first thing we want to do with this patient is to lower her estrogen level. One of the best ways to do that is to detoxify the liver. So I gave her a powdered drink to detoxify the liver. You can do a 1 week, 2 week, or 3 week. I did 2 weeks for her, and it did bring down her estrogen levels. We did let her know that, she does ovulate, so having intercourse more frequently would probably result in a pregnancy. All these patients I do put on prenatal vitamins with omega-3 fatty acids. It helps the adrenals and also helps prepare the patient. Now, I did advise her that she probably doesn't want to try and get pregnant for at least 6 months because cortisol and DHEA are not normal, and commonly this will result in a miscarriage. So we want to normalize cortisol and DHEA first, or at least move in that direction. Stress reduction techniques, again, she's on the prenatal vitamins. Very important to look at adaptogenic herbs. We don't know if they're safe in pregnancy or not, so I did start her on adaptogenic herbs, but again, cautioned her not to try and get pregnant for 6 months. At that point, I did take her off of adaptogenic herbs. She was pregnant about 17 or 18 months later. So we had really good success with this patient. These are the kind of things that we're going to be looking at in case histories. We have really a jam-packed 4 days for you and a lot of world-class presenters March 3rd through 6th in San Francisco at the BHRT Symposium. So I hope you will join us for the symposium. Again, there'll be lots of case histories. It begins actually the first evening. I'll be speaking for several hours on what you must know about women's hormones to kick off the event, and then the next 3 days more as well. So I hope you will join us, and I'd like to open it up now, Lindsay, to some questions.
Sure, absolutely. If anyone does have any questions, again, please submit them through the chat option. And in the meantime, I again wanted to thank you, Dr. Smith, for joining us tonight. And as a special gift to our attendees who are on the webinar tonight, we would love for you to come and celebrate with us. And we are offering $100 off of your registration. We do look forward to seeing you. The direct phone number to call to take advantage of this gift is 561-777-6807.
You want to repeat that again, Lindsay?
Sure, absolutely. Again, the direct number is going to be 561-777-6807. Currently, we do have the early bird special going on for $7.99. So with your $100 discount, it would be $6.99 for the 4 days. And I believe we have a question coming in, Dr. Smith. One moment.
Great.
Dr. Smith, what kind of liver cleanse to reduce estrogen?
Well, there's a lot of different companies that are nutraceutical companies that make great liver cleanses that actually have clinically controlled trials. Zymogen makes an excellent one, Metagenics, Orthomolecular, Designs for Health, Biotics. I mean, there's a lot of Numedica. There's a lot of really good companies. I've used many of those companies myself personally in my practice. I could recommend any of them. I'm sure I left out some other good companies as well.
Great, thank you. Dr. Smith, what are your thoughts on hormone pellets?
Well, from the viewpoint of pellets, it's a little harder to control what we're trying to do in these cases, because if you happen to get the wrong dose, you really can't usually find the pellet to take it out. So, there's a lot of different ways to give hormones. Certainly pellet therapy is one of those. It's not my personal preference. It is some of the other presenters, and so I think we all have our favorites. And that's the great thing about the symposium, because you'll learn different techniques.
Great. Another question, Dr. Smith. Is blood testing equivalent to saliva? Does insurance cover saliva testing?
That's a great question. It depends on the company you're using for saliva testing, and there are many insurances that pay a good portion of saliva testing. When it comes, this is the science, when it comes to hormones that are applied transdermally, then there are several studies showing, and you'll see the research actually at the BHRT Symposium. If the hormones are applied transdermally, then we know that serum testing is not accurate, because when you put the hormones on transdermally, it goes into the red blood cell, it stays for 3 seconds, it's gone, and it goes into the other tissues. And so for transdermally applied hormones, serum is not accurate. For PO hormones, then it is. So that's your answer to that question. But again, you'll be seeing some of the literature at the symposium.
Great. Dr. Smith, can you recommend any tests for BHRT?
I'm not sure what the question is, Lindsay.
Possibly referring to lab tests. Do you have a few lab companies that you can speak on?
There's a lot of great labs that, for instance, do saliva testing. There's a lot of great labs that do urine testing. There's a lot of them, from Genova to ZRT to neuroscience to AML to, there's many of them actually. I just mentioned a few of them.
Okay, wonderful. What about textbooks? Can you reference a book of choice?
Well, my favorite book on this subject actually is The second book I wrote on hormones, What You Must Know About Women's Hormones. And if you would like a copy of that and you're on tonight, then please email me at faafm63@yahoo.com. That's faafm63@yahoo.com. And I will be glad to send you a copy wholesale, or my book, What You Must Know About Women's Hormones, will be available at the symposium as well.
Great.
A lot
Dr.
of
Smith,
good
sorry, there's a lot of great questions coming in. We want to be mindful of everyone's time, so I'm going to address the last question with you, Dr. Smith. And if anyone else does have questions, please certainly use this function, and we will address them by email. Dr. Smith, do you ever recommend cortisone to lower cortisol levels?
Well, we don't recommend giving cortisone if the levels are too high. If the levels are too low, then our last resort would be to give something like Cortef. But that's always the last resort. Again, here we're not talking about Addison's disease. We would be talking about cortisol levels that are too low. So they do exist, unlike Addison's where people don't make cortisol. These people just don't make enough, otherwise known as hypocortisolism or adrenal fatigue. There are many ways to treat that. I'll be going over that extensively, as will the other presenters at the symposium. But the last way we would treat that, the last resort, would be to give Cortef, and you will learn how to do that at the symposium as well.
Great. I also wanted to highlight before we sign off, there will be on the first day, which will be on March 3rd, we will be explaining how to incorporate BHRT into your practice, so a very fantastic opportunity. Again, thank you so much, Dr. Smith, for your presentation. We do look forward to seeing you in March. Again, please call 561-777-6807 to reserve your spot with this amazing faculty.
Thank you very much, Lindsay, for running this webinar, and thank you everybody for attending tonight.
Thank you, and good night.